Hello, everyone. Thank you for being with us today. My name is Nita Joseph. I'm a program officer at the Center for Healthcare Strategies. I'm a Black woman with dark hair that is pulled back in a low ponytail. I'm also wearing glasses and a green long sleeve top. I'm pleased to welcome you to our third public stakeholder meeting regarding the California Department of Healthcare Services and the California Department of Aging Gap Analysis and Multi-Year Roadmap for Home and Community-Based Services and Managed Long-Term Services and Support Projects. We look forward to sharing updates about these two related but distinct projects, as well as giving you several opportunities to ask questions and to share comments. Before we get started, I would just like to cover some logistics. Today's call is being recorded and will be made available to you and those who are not able to attend after the call. To eliminate background noise, phone lines have been muted as you join the call today. There are a few important accommodations that we wanted to make sure you know about. First, if you would like to use the closed captioning feature, you can click on the CC icon that's at the bottom left of your screen. We also have live ASL interpreters here with us. Their names are Remy Godwin and Kathy Godwin. If you'd like to see the ASL interpreters throughout the meeting, you can right-click on their names and click on the function that says pin to keep them on your screen. We also have a live cart interpreter available, which is a live captioning service that's similar to the closed captioning feature on Zoom, but is a more accurate version, and that service is available in both English and Spanish. My colleague Ashley will put that specific link in the chat so you can click to access the live cart recording. Continuing on, there will be two separate opportunities to ask questions. First, there will be a one 10-minute Q&A session after we provide an update on project, stakeholder, and consumer engagement activities. At that point, we'll answer as many questions as possible that come in via the chat function or from anyone who would like to use the raise hand function and ask a question live. Then at the end of the meeting, after the updates on the gap analysis program inventories, there will be a 25-minute Q&A session where we'll do the same thing. And of course, you can use the chat function throughout the meeting. We're committed to ensuring effective communication and equal access. If anything becomes inaccessible during the meeting, please send a message to me in the chat. Today, Today we plan to cover the following. First, we'll start with introductions, followed by opening remarks from both DHCS and CDA. Then we'll provide an update on the stakeholder and consumer engagement component of this work. This will include what has occurred to date, what we've heard from you, and what else is on the horizon. The first Q&A session will open after that. Then DHCS and CDA will provide analytic activity updates on their respective projects. Finally, we'll close out the meeting with the second Q&A session and offer some brief next steps. That's all I have for now. I'm going to pass it over to my colleague, Courtney Roman, to begin with welcoming remarks.
Great. Thank you so much. Hi, Nita, and hi, everybody. We are so grateful that you are here today. My name is Courtney Roman. I'm a senior program officer at the Center for Healthcare Strategies, or CHCS, and I will be facilitating our meeting today. For those who need a visual, I'm a white woman in my 30s. I have long brown hair, blue eyes, and I'm wearing a dark green top. I am going to get us started with introductions, and we are going to start with our State Department partners. So we're going to first hear from Susan Phillip, who is the Deputy Director of Healthcare Delivery Systems at the Department of Healthcare Services, or DHCS. And then we'll hear from Susan DeMorris, who is the Director of the California Department of Aging, or CDA. So Susan Phillip, I welcome you to greet the group today, if you're ready.
Great. Thanks so much, Courtney.
Please.
Yeah, so I just want to, on behalf of the California Department of Healthcare Services, I just want to welcome you all. This is the project's third public sector engagement meeting. I really just want to take a second to thank you for joining us today, and for those of you who've been engaged in this effort so far, and thank you in advance for your continued engagement. So today our teams will provide an update regarding the statewide gap analysis and multi-year roadmap for our home and community-based services and long-term services and supports project. And this project is really pivotal to help us identify key gaps in California's HCBS and long-term service and support programs. It's also pivotal in helping us ultimately develop a roadmap for closing gaps so that our members, our beneficiaries, really have an integrated experience as they access and obtain these critical HCBS and LTSS services that support their well-being and health. This project really will continue to build on our current work within the state, particularly under CalAIM, which stands for California Advancing and Innovating Medi-Cal. And we're really seeking, to improve our enrollees' experience again through this effort, and have this effort inform implementation decision points, again, to build a more equitable and integrated, inclusive long-term care system. So we really look forward to learning more from you and working together on achieving these shared goals. So again, on behalf of the Department of Healthcare Services, just want to thank you for your commitment, your partnership, and of course, your valuable time. So with that, I'll turn it back over to Courtney. Thank you.
Thanks, Susan. And now I will turn things over to Susan DeMorris.
Thank you, Courtney. Good afternoon, everybody. Susan DeMorris, Director of the California Department of Aging, and we are so proud to be part of this work and to be collaborating with our partners at the Department of Healthcare Services. I want to thank the CDA team working on this effort and all of our stakeholders looking at the we just went over 200. Looking at the number of participants, so many of you are engaged in this work in other settings. And so your input and feedback is just critically important today in this webinar, but also in the many other places that you bring forward, your experience as providers, consumers. We want to continue hearing from you. Tomorrow we release the third annual Master Plan for Aging report to the legislature. And this is one of the achievements that we tout in 2023. This is a multi-year endeavor, the gap analysis and roadmap, and we will be working alongside you for years to come as we perfect this work with your input. So thank you all for your participation today and for the work that's ahead. And now I turn it back to Courtney.
Thank you, Susan. Appreciate that. Okay. So we have, there are 4 project partners involved in this work. DHCS leads the Medi-Cal side of the project and provides key data for the gap analysis and multi-year roadmap project. CDA, California Department of Aging, leads the non-Medi-Cal side of the project and provides key data for the HCBS program inventory and gap analysis and multi-year roadmap project. Then our colleagues at Mathematica developed the analytic approach. They are conducting quantitative and qualitative analysis, and they'll be writing the gap analysis and multi-year roadmap documents. And then finally, the Center for Healthcare Strategies, or CHCS, my organization, we're leading the stakeholder and consumer engagement activities throughout the project. Next slide. Great. So just to round out our introductions here, we are really fortunate to have all of our project partners with us today. So you already heard from Susan Phillip and Susan DeMorris. We are also joined by Joseph Billingsley, who's the Assistant Deputy Director of Healthcare Delivery Systems at DHCS. We have Sarah Steenhausen, who's the Deputy Director of Policy Research and Equity at CDA. Tanya Batista, the Policy Chief from CDA, is here as well. And then we also have Patricia Rowan, who is the Principal Researcher at Mathematica. And my colleague, Sarah Triano, is the Associate Director of Long-Term Services and Supports and Disability Policy at CHCS. Of course, you already know me. Next slide. So the purpose of today's meeting is to bring stakeholders and the public together for an update on the gap analysis projects. You're going to hear really shortly from our colleagues at Mathematica, DHCS, and CDA to provide some new updates on the analytic activities for the gap analysis and the multi-year project work. Now, if you joined our previous public stakeholder meetings, like Susan Phillip noted, this is their third one. So if you joined in January and July of 2023, you know that a key part of this work really includes stakeholder and consumer engagement. When we met previously, you'd heard about the various opportunities that would be available for stakeholders to weigh in on. So in our meeting today, we are excited to be providing an update on those opportunities, as well as a summary of the first set of consumer listening sessions, which took place in the summer and fall of 2023. So with that, I am going to turn things over to my colleague, Sarah Triano, who's going to lead the update on consumer engagement review. So Sarah, on to you.
All right, thanks so much, Courtney, and good afternoon, everyone. Thank you for joining us. Before I begin, I'll describe myself for disability access purposes. I'm a white, straight, cisgender woman pushing 50 years old with shoulder-length red hair and gray hair too. There's some gray in there, and green eyes. I'm wearing a blue long-sleeve shirt. And I proudly and openly identify as a woman with lifelong physical disability and also with bipolar disorder. I'm the mother of 2 children with disabilities and the caregiver for 2 older adults with disabilities, my 2 parents. So none of this is hypothetical for me or for any of us. This is very real and very important. And I share the honor with my colleagues at the Center for Healthcare Strategies in leading that stakeholder engagement work. And I'm going to give you just a quick overview today of what's been done so far in that space. Next slide, please. So our stakeholder engagement efforts are guided by 3 main goals. So the first one is to make sure that a wide variety of stakeholders, from folks who need and use home and community-based services to caregivers, providers, advocates, that everyone knows what's going on with the project and that you all have an opportunity to provide input at all stages. A second goal is related to one of the main objectives of this project, which is to reduce inequities in access to and usage of HCBS. So we're helping to identify those inequities by holding consumer listening sessions with diverse demographic communities throughout California. I'm going to talk more about those in just a minute. But the key to all of this, though, our third goal is to make sure that we get your diverse stories and suggestions to the Department of Healthcare Services, to the California Department of Aging, and to Mathematica in a timely and effective way so that they can be taken into consideration in the gap analysis program inventory and roadmap. Next slide, please. So since this project launched in late 2022, over 741 stakeholders have been engaged so far through several different mechanisms. So we've had, as Courtney already mentioned for you, the 2 large public stakeholder meetings previously, and if we're at 219 participants right now, and if we get to the approximately 400 people that are registered for this call, that'll be over 1,000 stakeholders engaged so far. We've provided 3 updates to the full Disability and Aging Community Living Advisory Committee, including additional meetings with the Housing and Transportation subcommittees of the DACLAC. We had a small group consultation in May to specifically discuss data and data methodology. There was a joint meeting in June that all DHCS and CDA advisory committees members were invited to. We've done presentations at the Advancing States HCBS conference in August and another for the State Alliance team in September. And we've held, as I mentioned, these consumer listening sessions between we've done 6 of them between June and September with 59 participants, conducted in partnership with Ad Lucem, a woman-owned public consulting firm in California. There are many, many additional activities that we have not listed here, including California Community Transitions, CCT roundtable meetings, PACE work groups, lots of others that are too numerous to list. But for today, I'm going to really focus on the consumer listening sessions and what we learned from them. So next slide, please. For the consumer listening sessions, in addition to Ad Lucem, we partnered with trusted community-based organizations that were compensated to lead the recruitment, registration, and provide outreach materials in English, Spanish, Chinese, and accessible formats. Participants were asked to complete a brief demographic screener, a form, so we had a better idea of who was in the room, what home and community-based services they used or didn't use, who wasn't at the table, and therefore what voices we would need to be elevated in future listening sessions. All of the listening session participants received compensation for their time and experience in the form of a $100 Visa gift card. The 6 sessions were held in both rural and urban areas in Northern, Central, and Southern California. 4 of the 6 sessions were conducted exclusively in Spanish, Mandarin, or Cantonese. And session participants included users of in-home supportive services and other Medi-Cal funded HCBS programs, caregivers, personal attendants, folks receiving non-Medi-Cal HCBS services, folks needing but not receiving any kind of HCBS, and parents of adults with intellectual and developmental disabilities receiving regional center services. Next slide, please. So just a little bit of information about who was in those sessions. 81% of the consumer listening session participants identified as female. 49% were over 65 years of age, with the largest percentage being between 65 and 74 years of age. There was 32% were in that age group. And most participants self-identified as Hispanic or Latinx, 42%, or Asian Pacific Islander, 36%. Next slide, please. 51 participants self-reported as having a disability. Some had multiple disabilities, with 73% having a physical disability, 37% had a mental health disability, 29% had a developmental or intellectual disability, 25% had a sensory disability, and 20% had a cognitive disability. Next slide, please. So in the past 6 months since they filled out their demographic form, the consumer listening session participants reported using a wide variety of home and community-based services, with the top 4 most used services being personal attendant care, information referral care coordination, durable medical equipment, and accessible transportation. Next slide, please. In the consumer listening sessions, participants were asked to share their experiences and opinions on some very specific things. We asked for information about how they were referred to and how they were using home and community-based services, the benefits of HCBS, their language and cultural needs and any health disparities, challenges to receiving HCBS, what their needs were for additional HCBS services, and then any recommendations that they had for improving HCBS in California. And participants in all 6 sessions shared that they most often found out about home and community-based services from friends, families, neighbors, basically through word of mouth. One Mandarin-speaking participant expressed a common frustration that, quote, apart from references or recommendations from friends, I don't know whether there is an organization or resource place which is more centralized and that you may be able to find such resources. That was a common thing that we heard. Improved mobility and independence was one of the 3 most frequently cited benefits of home and community-based services by participants. There were lots, but that one really stood out. And a Cantonese language participant noted that they would, quote, need to make 3 transfers on public transport to get to the doctor if it weren't for the HCBS transportation services they received. And a family caregiver, and another along the lines of improved mobility and independence, a family caregiver also noted how the personal attendant that was serving their adult child with a developmental disability contributed to their child's independence in dressing and bathing. They said, "It's not that he doesn't know how to do it, but he depends on me a lot, and the personal attendant slowly got him used to being away from me so he could manage on his own." Participants in all four Mandarin, Cantonese, and Spanish language listening sessions expressed difficulty finding or accessing language appropriate services. One Spanish-speaking participant shared that even though the HCBS eligibility worker described everything to them in Spanish, all the paperwork that they got was in English. And cultural access to HCBS emerged as a challenge in all 6 sessions as well, ranging from one participant who got negative comments from their IHSS worker about their holiday and home decor because it wasn't in line with the worker's cultural and religious beliefs, to other participants who noted the very limited variety of culturally appropriate meals available. They said that they had culturally appropriate meals, but there was a very limited variety of them. And continuing on the next slide, some of the other key themes that we heard across all 6 of the listening sessions, participants discussed having HCBS needs that were greater than the amount of services that they were receiving. And participants in Cantonese and Spanish language sessions specifically reported that they had to use personal financial resources to supplement approved services. Participants in half the sessions perceived the wait times for HCBS services as being very long, and challenges finding HCBS providers were raised in all 6 sessions. The limited pool of available personal attendants in rural areas was noted, along with the challenge finding attendants in competitive urban markets, where it was shared that the amount of the approved attendant pay for that area was not adequate to get high quality, consistent service. So a participant from Southern California area said that the pay rate for providing services and respite care is so low that it's impossible for us to hire someone. Some of the other challenges and unmet needs that we heard about were unmet transportation and mental health needs. Both came up in 5 of the 6 sessions. Long distance transportation across counties or state lines was noted as a particularly difficult challenge. Nutritional support and assistance with home repairs, yard work, paperwork were also all perceived as needed home and community-based services that were either unavailable or insufficient. So, at the end, we asked them, what would you do to strengthen HCBS services in California? And participants, they recommended a lot, but there were a couple really big themes that stood out in many of the sessions. Participants recommended one was to enhance the promotion of and communication about home and community-based services within the state through a variety of ways, including one group suggested the development of an HCBS directory available in multiple languages that includes up-to-date HCBS information and clear, accessible service descriptions, including what HCBS workers can do and what they can't do. And participants in 5 of the 6 listening sessions also recommended things to improve access to and continuity of home and community-based services, including one group that recommended universal access to HCBS for workers in California, regardless of income, and another that recommended simplifying the application and eligibility process. Next slide, please. So building off of what we heard from all of you last year, and from what we heard from all the folks in these listening sessions, and from, building off on who we still haven't heard from yet, we're proposing to conduct consumer listening sessions this year in 2024 with the following groups in no particular order. So folks who need and use home and community-based services who are members of Indigenous communities. This is a recommendation that you all made at the last public meeting in July. We've got one planned for that. LGBT, lesbian, gay, bisexual, transgender, queer, plus HCBS users and caregivers, a group there, since very few of the listening session participants so far have identified as such. A group with HCBS developmental disability waiver participants themselves, ages 18 and older. And another group with older adults with developmental disabilities who also have a cognitive disability, such as dementia. We're also looking at paid and a group with paid and unpaid family caregivers, with family being in the broadest sense of the term, including chosen family. HCBS users with mental health and or substance use disabilities, and HCBS users who've transitioned from fee-for-service to managed care for any aspect of their healthcare, along with maybe assisted living and home and community-based alternative waiver users. So again, this is just a proposed list and may change later, but we wanted to share with you where it's at right now. So with that, we have some time to take some questions. So I'm going to turn it back over to Courtney to moderate any questions or comments that you have about what I've shared so far related to the stakeholder and consumer engagement work of this project.
Great, thank you so much, Sarah. Yep, we have a few minutes here for Q&A. So we are happy to take questions from folks who raise their hands. And then of course, you're always welcome to put questions in the chat as well. So I think I saw Michelle's hand up first. Michelle, if you want to ask your question.
Yeah, you're basically saying that you're going to reach out to more consumers and get their input about their gaps in services. When you do that, make sure that you get a decent population that is underserved, who are under 65 also, that don't always have access to referrals and other services. For many years, I've fallen in between the gaps before I turned 50 and didn't get that additional help that I had to seek out and get. So I hope you are able to get to those consumers in a way that's productive for this. Thank you.
Thank you.
Appreciate that, Michelle. Connie, I think you had your hand up next.
Sorry, technology is a little difficult.
Hey.
I think that I would like to be involved in whatever you're going to be doing as far as further listening sessions. I think that it's important to have a distinction between people with disabilities who are aging with disabilities and older adults who are maybe getting disabilities, because that is a distinct population. And also, I had actually 3 questions. I'm wondering what is being done in terms of alternative HCBS waiver initiatives in place as aimed at basically at differentiating wages for IHSS and waiver participants and people particularly with complex chronic conditions, quadriplegia and functional quadriplegia, because I think those are going to be very important. And with the wages currently being raised for fast food workers to $20 an hour and up to $25 an hour for healthcare workers, it is creating greater shortages. And I'm wondering, what are you doing to address wages and job incentives for home and community-based services providers being prioritized to be in parity with those of institutional and fast food workers? Thank you.
That's an important point. We appreciate that, Connie, very much.
And just, I believe, we may table that question until a little bit later conversation.
Let me take, Miriam, I think you had your hand up next.
Hi, can you hear me okay?
Yes, absolutely.
Hi, my name is Miriam, and I'm calling from the Congregate Living Health Facility Association. So Congregate Living Health Facilities are a provider to HCBA waiver recipients that are not able to live in their own homes for many different reasons and reside in a congregate living health facility utilizing the HCBA waiver. So my question is regarding the gap analysis, were congregate living health facilities included in the data collection for this gap analysis? Because I never gave my input, and I haven't heard of anybody in our field who has. So can somebody look into that and maybe answer a question?
Miriam, we're going to talk a bit more about the gap analysis specifically in the next kind of section of presentations here. So we can come back to that. Although I'm not, we'll come back to that in just in a bit, if you don't mind.
Thank you, no problem.
Sure. I'm going to take one more, and then I know there are lots of questions in the chat too, and we will get to those. I don't want to, do not worry. We have lots of time at the end, allotted for questions too. Marty, do you want to ask your question?
Yeah, I do. Thank you, Courtney, and
Of
thank
course.
you to everyone, the team from Department of Healthcare Services and California Department of Aging for doing this stakeholder update and also the previous ones. It's been really valuable, and also the local engagements. So I really appreciate that. My question is, I put it in the chat, but I do want to say it out loud, is how does the gap analysis address, if it does at all, proposals in the state budget, or proposals that are being proposed, or those proposals that will be enacted that will have effect on the availability of HCBS services potentially, such as the proposal to delay the regional center rate model implementation by 1 whole year. Also, is the gap analysis looking at, and I can't remember if it did, on the issue of looking at extensions of remote services for people with disabilities and developmental disabilities, and how does that impact gaps in services, or does it help improve it? And lastly, will the gap analysis, and maybe this is something later you'll be addressing, try to make recommendations in real time, or what's your point in time? Because if you looked at something, you interviewed people 2 years ago, if circumstances have changed, such as if there has been budget cuts, how do you address that so that the information is accurate? And again, I appreciate all you're doing. This has never been done before. And so well, hopefully something good will come out of this. So thank you.
Thank you, Marty. I think we'll get to some of the gap analysis questions in the next part of the presentations. But if we don't, please raise that again at the end, okay? All right, so we are able to move on to our next section of the presentation. We are going to turn things over to Joseph Billingsley at DHCS, Department of Healthcare Services, who's going to lead the beginning of the gap analysis. And there will be still be ample opportunity to get all of your questions asked and answered. Don't worry about that. But we will turn things over to Joseph for now.
Great. Thank you, Courtney. Welcome everyone, and thank you all for being here today. We really do appreciate your ongoing engagement in this process. I see a lot of the familiar faces, and always happy to see many of you really participating in these important projects. Just to quickly introduce myself again, Joseph Billingsley, Assistant Deputy Director for Integrated Systems with Department of Healthcare Services. I am a middle-aged white male with brown hair and a short beard with quite a bit of gray and white in it. And I'm wearing a gray suit jacket and light checkered shirt. And so just to continue on, my goal here is to ground us in the goals of the Department of Healthcare Services, HC or Home and Community-Based Services, gap analysis, and roadmap to manage long-term services and supports. And then I'll be handing back to our Mathematica partners to present updates on the approach. Thank you. Sorry, I had to mute real quick. So just to dig into this slide, as we've previously mentioned, there are three primary goals of the Department of Healthcare Services, HCBS, or Medi-Cal Home Community-Based Services gap analysis and multi-year roadmap. And those include, to one, identify and analyze opportunities to close gaps in access to home community-based services, to address and close identified gaps as the state transitions to manage long-term services and supports for select home community-based services programs, and to improve health outcomes, consumer satisfaction, and health equity for Medi-Cal members in California. The Department of Healthcare Services is grateful for, and really we very appreciative of the stakeholder feedback that we've received to date, as it has been instrumental in shaping the work so far and continues to inform what we're doing and what you will hear Mathematica speaking to shortly. Next slide, please. So this slide provides a high-level overview of the major milestones for the Department of Healthcare Services Medi-Cal Home Community-Based Services Gap Analysis Project. Our team continues to collect and analyze data for the gap analysis. Our team did receive a initial draft of the gap analysis report from Mathematica in late September, and Department of Healthcare Services reviewed that draft and provided feedback back to Mathematica, which is helping to inform future upcoming drafts of the gap analysis. And once the Mathematica's finalized the analytic work in the Medi-Cal or Home Community-Based Services gap analysis report, then they will begin drafting the multi-year roadmap, which is planned for submission to the Department of Healthcare Services this summer. So just identifying that you can see in the third year, which is July of 2024 to June of 2025, Mathematica will also be working with the Department of Healthcare Services to make updates to state and local policies and procedures to implement the multi-year roadmap. And then finally, for our managed long-term services and supports, the goal is to initiate strategies for applicable waivers per the roadmap to work towards initiation of achieving managed long-term services and supports integration, working towards that integration beginning in 2027. Next slide, please. Just to again talk through the main objectives that are identified within Department of Healthcare Services, HCBS Medi-Cal, or Home Community-Based Services Medi-Cal Gap Analysis. Those objectives include to one, reduce inequities in access and services, also to meet client needs, and then also improving quality improving quality. And it's important to note that we've bolded those three objectives on this slide to really identify that they've been the priority focus over the previous 6 months and will be the focus of today's updates. Future meetings will provide more detail on objectives 3 and 5, which include increasing program integration and coordination and also streamlining access. Next slide, please. So just to talk through the programs that are included in the Medi-Cal Gap Analysis and Roadmap, and to add some additional context. So we've included the programs that are included in the Medi-Cal Gap Analysis as well as the multi-year roadmap. And so these include several home and community-based services programs, including the multi-purpose senior services program waiver, the home and community-based alternatives waiver, our assisted living waiver, as well as in-home supportive services and California community transitions. In relation, we also want to highlight services that are provided currently under Medi-Cal managed care, and that includes long-term care that is provided in nursing home and other settings, as well as the program of all-inclusive care for the elderly, or PACE program, and as well as community-based adult services, and also community supports and enhanced care management for members that are at risk for institutionalization or in nursing homes and can transition to the community. And then also complex care management and transition of care services. It is important to note that the analysis currently excludes programs for individuals with developmental disabilities and also the Medi-Cal waiver program. And so with that, I will go ahead and turn back over, or I'm going to turn the presentation over to Tricia Rowan at Mathematica, who will provide updates on the project's analytic approach and work. Thank you.
Great, thanks, Joseph. Hi, everyone. As Joseph and Courtney have said, my name is Patricia Rowan. I'm a principal researcher at Mathematica and have the great honor of directing the team working on both of these gap analysis initiatives. I am a white woman with unruly, curly brown hair that is pulled up in a ponytail, and I am in my home office where my background is a blue wall and a houseplant that is taking over my home office. So thank you again for having us and being here. As Joseph said, I'm happy to provide some updates on our analytic progress. Under objectives 1 and 2, which are related to meeting client needs and improving access, our team has produced descriptive profiles of long-term services and supports users and providers. We've also examined how those trends in long-term services and supports use have changed over time. We have mapped out the locations of current users and providers of long-term services and supports to see where there may be mismatches between the current supply and demand of long-term services and supports. We created forecast models to forecast future growth in demand for long-term services and supports among older adults and folks with disabilities in California. And as Joseph mentioned, we have drafted the first iteration of the gap analysis report, which was reviewed by many layers of leadership at the Department of Healthcare Services. That version of the report, just to answer a question in the chat, was not released publicly. It's still going through internal review. We're making updates to incorporate more data. We're updating it this spring and summer, and we hope to share it publicly later this year. Next slide, please. Under Objective 4, which is related to quality improvement, this objective was designed to generate a set of recommended quality measures that could be added to the DHCS long-term services and supports data dashboard. And our analysis resulted in a feasibility. We did a feasibility study with lots of staff at the Department of Healthcare Services to refine those quality measure recommendations. Those interviews were really focused on the nuts and bolts feasibility of collecting accurate and timely data, the systems that are needed to do that, how to validate that the data is accurate, and priorities for measurement. And additionally, we provided the Department of Healthcare Services with a set of recommended quality measures that are aligned with the Center for Medicare and Medicaid Services, or CMS's, HCBS quality measure set that is in their proposed HCBS access rule. Some more work to come on that. Next slide. While we have completed quite a bit of analysis to date, we still have important activities still in progress, which include the following. We are doing an assessment or an analysis of the in-home supportive services, or IHSS, provider data and assessments. We are also analyzing data from the California Community Transitions, or CCT program, as well as the Program of All-Inclusive Care for the Elderly, or PACE. We are also exploring the availability of data on services to individuals with developmental disabilities. We launched a provider survey in December that was intended to provide more detailed insight into the capacity of select HCBS providers to serve beneficiaries in home and community-based settings. That survey was done in partnership with the California Department of Aging and the California Department of Public Health. It did close in mid-January, and we are working on cleaning and analyzing the data now. We're also collecting qualitative data to address remaining analytic questions under Objectives 1, 2, and 3, and supporting the Department of Healthcare Services in planning for the implementation of the Center for Medicare and Medicaid Services HCBS quality measure set. And finally, we are developing the multi-year roadmap for integration of select HCBS programs into a managed care delivery system. Next slide. All right, at this point, I'm going to turn the presentation over to Sarah Steenhausen at the California Department of Aging. Sarah will introduce the non-Medi-Cal Gap Analysis and Multi-Year Roadmap Project.
Thank you so much, Tricia. It's really a pleasure to be here today. As Tricia noted, my name is Sarah Steenhausen, and I'm Deputy Director of the Division of Policy, Research, and Equity at the California Department of Aging. I am a middle-aged woman, with blonde hair, and I'm wearing a navy blue top. I first want to just begin by thanking everybody who is participating today, and particularly those of you who have assisted with gathering information at the department level. This has really required a whole of government approach in terms of our partnership, not only with the Department of Healthcare Services, but also with our other California Health and Human Services agency partners, as well as the Business Consumer Services and Housing Agency and the Transportation Agency, who have provided us access to data on housing and transportation as a part of our home and community-based services analysis. I also just want to quickly really speak to the high quality of work that's being led by Mathematica, as well as our partners at the Center for Healthcare Strategies. All of this information is so critical to advancing the master plan for aging in terms of understanding the gaps in our system and helping build out a roadmap. So we're just really grateful for all of your efforts in this. Next slide, please. The gap analysis, the non-Medi-Cal home and community-based services gap analysis project has 4 main goals. First, to develop an inventory of non-Medi-Cal home and community-based services, including affordable, accessible housing and transportation. 2, to build on the Department of Healthcare Services gap analysis by developing a similar analysis that looks at non-Medi-Cal home and community-based services in California. 3, to develop a multi-year roadmap that will advance non-Medi-Cal home and community-based services infrastructure so that everybody who needs services can access those services statewide. And 4, to propose measures that will help us in monitoring our progress in advancing statewide home and community-based services infrastructure. And as mentioned earlier, this project and its goals are all part of our larger efforts to improve access to long-term services and supports in California, all of which is a key component of the master plan for aging. Next slide, please. For the inventory of non-Medi-Cal home and community-based services, we have organized it by program and services, which includes the following information about each program: eligibility requirements, geographic reach, service delivery, utilization data, and funding sources. Next slide, please. So this, our component of the project has used all publicly available program data, including the following programs and services: nutrition services, including congregate and home delivered meals, caregiver support, other supportive services, independent living center services, aging and disability resource connections, Older Americans Act programs and services, transportation and mobility services, affordable and accessible housing, as well as some other data sources. So next slide, please. I'm happy now to turn it back to Tricia with Mathematica, who will present the next set of slides speaking to the data analysis and inventory of this effort.
Thanks, Sarah. So these next 2 slides show the primary categories of a taxonomy that we have developed of non-Medi-Cal home and community-based services. These categories were assigned based on program level goals of each service in the program inventory. Each program in the inventory we've developed is associated with one primary category in the taxonomy. Services are labeled with secondary categories as necessary. The categories were created to categorize similar programs and services across departments and were informed by similar taxonomies, such as the one used by the Los Angeles County 211 system and the Transformed Medicaid Statistical Information System, which is the federal data system that the Center for Medicare and Medicaid Services has created. The primary categories are organized under domains, which were inspired by the World Health Organization's age-friendly domains of livability. These domains were chosen to align with the non-Medi-Cal HCBS programs and other taxonomies and to support the goals of the Master Plan for Aging. The taxonomy will be integral to supporting the state in successfully integrating non-Medi-Cal and Medi-Cal programs. Next slide, please. To help inform the program inventory, our team conducted key informant interviews with subject matter experts from all of the departments within the California Health and Human Services Agency that have responsibility for administering, overseeing, or otherwise managing the identified home and community-based service programs and services. These departments included the Department of Aging, the Department of Developmental Services, the Department of Housing and Community Development, and the Housing Finance Agency, the Department of Public Health, the Department of Rehabilitation, the Department of Social Services, the Department of Transportation, and the Department of Veterans Affairs. The purpose of these interviews, which we conducted throughout the summer of 2023, was both to gather input on the department-specific inventory and to provide insight into gaps and community-specific innovations. Next slide, please. This slide offers a high-level overview of the project timeline for the non-Medi-Cal Gap Analysis project. As mentioned previously, our team developed department-specific inventories and conducted key informant interviews over the summer last year. And looking ahead, we're now focused on the following. We are working to finalize the non-Medi-Cal HCBS inventory within the next month. We're also analyzing inventory and programmatic data to identify gaps in non-Medi-Cal HCBS between now and June. We will be soliciting feedback from stakeholders on gaps that are identified in the fall, and we'll be developing a multi-year roadmap to address identified gaps in early 2025. Next slide. So this now concludes the presentation for today. I'd like to pass things back to Courtney to open it back up for questions.
Great, thank you, Trisha. Well, that just flew by. Here we are at Q&A already. I know we've had lots of questions in the chat, so I want to honor some of those first. We'll read through a few of those, and then very happy to take Q&A from those who are raising their hands. Okay. I know that there was a particular question from Marty around the developmental disabilities waiver that I'm trying to get back to, that I know we want to, that we probably want to mention first. Okay, here it is. From Marty in the chat. Can we say again why this was directed for Joseph, but also invite Trisha from Mathematica to respond to, if you don't mind. Can you say again why the developmental services waiver or people with developmental disabilities are not included in Medi-Cal HCBS gap analysis? I know they're included in the non-Medi-Cal HCBS gap analysis. It's because it's included there, non-Medi-Cal, or for some other reason.
Hey, thanks. This is Joseph Billingsley again. Thanks, Marty, for that question. Really, I think so. The key pieces, one, the DD, or developmentally disabled population was not, waiver population was not included in the initial iteration of the gap analysis. That's due to several components. One, we've just been looking at available data in order to ensure that we're able to, or to look at what we are able to include in the gap analysis, and what we are looking at from in terms of the presentation of individuals accessing services through the DD waivers on 1915I. We are continuing to look at options to address, whether that will be addressed in the next iteration of the gap analysis or not. Recognizing where the DD population is being, as you referenced, captured in the non-Medi-Cal HCBS gap analysis. So I think that again, we're continuing to review and take into consideration how we are presenting information in the gap analysis, and welcome input from the group. And Trish, I don't know if there's anything you want to add on there.
No, nothing I would add to what you already shared. Thanks, Joseph.
Perfect. Thank you.
We appreciate the positive remarks in the chat. There is one question from Carol in the chat that's for DHCS. Can DHCS say more to clarify plans for integrating HCBS into Medi-Cal managed care? Would services comparable to HCBS waivers, so HCBA or ALW, assisted living waiver, be available statewide in every county, or would they potentially available as community supports, but optional for the managed care plans to offer some or all of those services?
Okay. So I can go ahead and take this question also. Again, so just to clarify, like, these are things that we are looking at and planning towards now. So in terms of what does it mean to integrate existing waivers, and specifically looking at waivers like the home community-based alternatives waiver and the assisted living waiver. What does it mean to integrate those into managed long-term services and supports? As you know, many of you are all aware. Within our existing managed care delivery system as part of our CalAIM initiative, we've already launched through our managed care plans access to services like enhanced care management and community supports, and those are services which really many of them were developed to replicate services that have traditionally only been available through our home community-based services waivers and programs. So that's like that initial stepping stone of starting to establish a framework for managed care plans being able to provide those services. As we continue to look toward the next waiver term in 2027, that's where we're currently working to assess, and this gap analysis and roadmap is a big part of that process of how do we move further down that road towards more fully integrating these actual waivers, assisted living waiver, home community-based alternatives waiver, into our MLTSS system. What does that look like? What authorities does that utilize? What does it mean for, is it a full integration of the waiver, or would there be any remaining services that would have to, remain in a waiver? So those are all pieces that we're looking at in this process. But really looking to make clear that, and also how, what we do with community supports within the managed care delivery system, how those potentially grow and transform. So really just a long way of saying that, those are great questions that you're asking, and those are questions that we're looking at and asking ourselves. So really appreciate your continued input there as we plan towards envisioning what that MLTSS integration looks like. Thank you.
Thank you, Joseph. We'll take a few raised hands now. Jeff, I think you were absolutely first. So if you want to come off mute and ask your question, you are welcome to do so.
Okay, thank you. So it's more of a comment than a question, although it could be a question. This is based on a point that was made by Sarah Triano in her discussion, specifically that there were reports of people with issues concerning preparation of paperwork. I represent the California Council of the Blind, and for 3 decades, we have been attempting to amend the IHSS program to solve this problem for IHSS recipients with respect to people with print disabilities and having the benefit of reading and completing documents. Our last collaborative effort with UDW ended by a veto from Governor Brown about a half a dozen years ago. We raised the issue in the Aging Master Plan discussions, as did others, but unfortunately has not yet gotten traction. And I guess my question would be, when will the state give some traction to this issue? And I thank you very much for that.
Thank you, Jeff. Joseph, I don't know if you have any thoughts to add there.
I appreciate no, I appreciate the your comments and feedback, and definitely something that I do want to take back and for consideration as we move forward. I don't know if anybody else wanted to add anything in.
Appreciate your comment, Jeff. We'll always bring those things back. And I know Jeannie had her hand raised.
Okay, thank you. I had to unmute.
Sure, of course.
It's always nice to see so many faces that I recognize on these calls, and thank you all for the efforts that you're putting forward, and the state for doing these. I have a couple of comments. Number one, first of all, I am the president of CICA, California IHSS Consumer Alliance, so really involved with all of the things that have to do with community-based services for those that use home care and personal care assistance. As you probably know, the statewide bargaining committee is being developed right now, an organization at the state level to talk about statewide bargaining for IHSS. And I think for those folks at Mathematica, Patricia, that your folks, it would be really beneficial for you to follow that committee, because I think you're going to find a lot of comments and concerns as that committee develops and has the stakeholders there that would really be important and for you to know about, as far as the gaps that are currently available are not, that are the gaps that exist in the system today. I also wanted to talk about the possibility of differential pay. I know we've been talking about this and how beneficial it would be for those IHS consumers that have high physical needs as opposed to just homemaking needs. And with the tremendous difficulty exists now in the state with finding providers, not only IHSS providers, but even private pay providers to do this work. I think if we could look at the changing the payment schedule would be beneficial. I also wanted to know, in the non-Medi-Cal area, whether you are looking at private pay folks that utilize their own money to pay for providers. You know, there are all those folks in the gray area that can't afford going to home care facilities or agencies and don't and are not eligible for IHSS or Medi-Cal. So I would really hope that you would, I don't know how you would do that, Patricia, would be really beneficial to try to find folks that utilize and are in that gray area to get their input into the gaps. Thank you.
Thanks, Jeannie.
Courtney, do you want me to
Yeah.
answer what I can of Janie's question? Janie, thanks for the heads up around the state bargaining committee. We will be sure to follow that. To your question about whether private pay folks are being picked up in the non-Medi-Cal analysis, you're right. It's really hard when there's no because if you're paying privately, your data is not really being captured at the programmatic level, right? So we unfortunately are not able to do that in a systematic way, but we are hoping to engage those folks in more of a qualitative way. So they may be encouraged to join consumer listening sessions, focus groups. We're hoping to, in meeting with some provider agencies, we can also get at issues of private pay. But you're right, it's hard without a centralized data. I don't know if Sarah or Joseph want to add to that.
I think that's a great summary.
Agree.
Thank you, Janie. Debbie, I saw your hand was raised.
It is raised. Hi, thank you.
Hi.
Well, hello, everybody. I am delighted to be here. There maybe was a few years where I didn't think that this was actually going to come to fruition. I appreciate the work, and it's interesting, the split between DHCS and CDA. And at first there was a little bit of consternation on my part why we have to do things in different houses, but the fact that everything keeps coming back together and the information is being shared together is super important. And obviously I work from outside of the department context, so I don't understand why everything needs to be split up the way it does, but I appreciate that the learning is happening jointly. So just want to put that out there. I want to lift up Marty's comments in the chat related to developmental disabilities. We serve a lot of folks at Choice in Aging in one of our adult day healthcare programs that are people with developmental disabilities, some with also cognitive, some not, and all of them needing additional support from Choice in Aging related to case management and system navigation and caregiver support, which are not captured. They're not being delivered through the regional center, and it's not captured somehow. So I just want to lift that up. We see that every day here. I'm struggling to try and articulate this in a way that doesn't sound like me complaining. I just want to say there's so much input that I want to give, that I want our CCT staff to give, that I want our MSSP staff to give, that I want our CBAS adult day healthcare staff to give, that I want our Alzheimer's daycare resource center staff to give. But there's we're so radically understaffed right now that I'm on the floor doing direct care, and then I'm writing board reports, and then I'm writing grants on the weekends. And we're all plugging so many holes. I don't know how to fit this in to life. I finished half of my survey, and when I went to go back, the link didn't work. And I know you guys are working behind the scenes to help me be able to give that feedback, but just to carve out 15 minutes to fill out a form is something. I'm wondering if there are other, and maybe it's just me, sometimes it is. But when I show up at a meeting and can give input, I somehow feel like I can do that, but to actually carve out time to write something and do all of that, I'm less likely to do. So I wonder if there's a way to collect feedback that's not surveyed, or maybe you're doing those on multiple levels, but I just want to say I feel like we have so much information, rich information to give about the lived experience of service provision. I just don't know that we're doing a good job of it in this way. And I'm the only one at my organization coming to these meetings. I'm not pulling people out of direct service to come and talk, so I don't know. I'm just barfing that all out at you. It's not a criticism of you. It's just sort of, this is the reality of boots on the ground, and however you can tap us in a way that you can get that information, I would really appreciate, because I feel like we have so much to share. I just don't know how to fit it in. Thank you.
Thanks for that, Debbie. I will say one of our strategies has been to try lots of different avenues, so that if you can't come to all of them, hopefully you can come to one, or recommend folks to come to others. Across both initiatives, projects right now, we are just gearing up to do a lot of qualitative outreach. Some of you on the phone may have already heard from us around some of those things. So I think all I'm saying is there will be more opportunities, if that makes sense. And also maybe Courtney Roman, if we can put in the chat, we have inboxes for both of these projects. So even if it's the middle of the night or the weekend and you've got a thought that you have to get off of your chest, please email it to us. We keep track of all of that, and it informs our planning. So thank you, Debbie.
Thanks, Debbie. We really do read the inboxes. Promise.
And if I can just add in also, because I want to make sure I'd seen Marty's comment in the chat, and appreciate your input there as well, Debbie. But I do want to clarify that when I'm speaking to, when we're speaking to whether the Medi-Cal HCBS gap analysis will include DD. So definitely when we're talking about it's definitely going to reference how people access Medi-Cal services and HCBS through our different systems, including the waivers in 1915I for developmental disabled population. It's just looking at the extent to which data will be included in the report and that we're able to provide there. So I want to assure that we're not, going to have a gap analysis that doesn't even recognize that there's Medi-Cal HCBS being provided to individuals with developmentally disabled and how they access it through those systems. It's more so just looking at the extent to which we are able to include data around the developmental population and within the gap analysis. But that's something that we're continuing to evaluate.
Thank you, Joseph. Trisha, there's a question in the chat about the survey that I wanted to point to you, if that's okay. It says from Selena, I believe I heard that only a sampling of HCBS and ALW, assisted living waiver, providers were surveyed to provide gap analysis information. Was there a specific reason for not surveying all providers?
Yeah, thank you so much for that question. As the question alludes to, Mathematica and the slide also mentioned, Mathematica did recently field a web-based survey of select provider types. When I say select, I mean not every single provider type. So for example, we did not include congregate living facilities. We did not include skilled nursing facilities. This round of the survey focused primarily on home and community-based service, waiver agencies, and other provider types. So we have a full list if you need it. We did try to send the survey to everyone that we had contact information to. And so we pulled that contact information through lots of different sources from the Department of Healthcare Services and tried to do Google searching to try to find email addresses and other things like that. So we did our best to capture as many folks as we could. Future surveys may capture other provider types. And as I mentioned before, we're also engaging in a lot of qualitative data collection to try to capture folks that were not part of that survey. The survey did close on January 13th. So it's no longer open. If you had that email in your inbox and you were unable to participate, you can always send us an email to the inbox and we can give you a paper copy of that survey, at least for the next couple of days before my team starts booing me off the stage for offering that. But I hope that clarifies.
Thank you, Trisha. I really appreciate that. Connie, I know you have your hand raised.
Yes, thank you. Thank you very much. Thank you for holding this meeting. Thank you for all the state employees trying to work hard on this issue. I have to speak to the issue as an end user, as a person with lived experience of having lived in a wheelchair since age 6, from severe chronic juvenile rheumatoid arthritis. All of the hours that you give us for IHSS and home and community-based alternative services hours, HCBA, waiver personal care services, or any other services to try to remain living independently in our own homes, are not useful or meaningful to us if we can't find people to fill the positions for the hours that we live so we can lead the kind of life and the goals and pursue the desires and dreams that we have. I think that people with disabilities are a distinct group because we come from a civil rights perspective of the civil rights movement, and older adults are not necessarily embracing the same vision that we have for inclusion under services as our rights are concerned. So I wanted to say, besides the hours, if we can't access backup services or people are excluded from county backup services because they don't have a provider, or we're sent another useless list from a third-party entity that we can't find anybody that wants to fill in a backup, and we're actually in a crisis of finding care, and we can't even cognitively or have the physical ability to make all the calls to beg somebody to come help us so we don't end up institutionalized, is a problem. We have aging family members who are helping us. Aging family members who I know even in my, younger days, they weren't 700 miles away. And I'm like, I can't get to bed. I don't have help. What should I do? And they're like, well, we're 700 miles away. I've sat out on the street corner late at night, begging somebody coming down the street to untie my shoes because somebody left a knot in it and didn't make it so it was easy for me to undo the shoes. We have endured abuse from abusive caregivers. And that doesn't mean they're all. There's many good caregivers, but they're hard and fewer and far harder. It's a lot harder to find anybody to work now for the wages that are out there. You have no idea. I get calls from people all the time begging me for help. This issue has to be solved. You have to understand there's two distinct populations: older adults aging with a disability who often don't want to be conceived as having a disability because you're viewed as less valuable or as damaged goods. You have people with disabilities that are proud and disabled that want to be able to do everything that we want to do. These are distinct groups. You have a distinct population of IHSS users. IHSS users who are happy they have family member providers who want to maintain that relationship and want to stay in that role. Then you have people who are disabled who want to live independently but don't have a choice because there aren't any caregivers. You have people who are living in the community that are struggling to stay living in the community because they can't find providers and they can't access backup care, or some entity says, here's a list for you, call these people, and everybody says, sorry, there's nobody available. And then the list you get of people, you can't find somebody who you feel compatible with to work for you that meets your choice. Like, I don't want somebody with long fingernails. All of these issues are very important. It's somebody that can do your routine without hurting you. Getting back to, you asking a question. I mean, differential pay. Somebody brought up there's going to be a statewide public authority in the bill 1672. I think that was Janie. Well, my concern is raising wages across the board county by county isn't going to do any help for those of us with severe impairments, because people are still going to pick the easier people that require less help than the people with the significant disabilities. And that is why it's critical to have differential pay, meaning provider, for instance, differential pay for providers willing to work for people with severe impairments, people who have no relative or live-in providers, recipients that have severe impairments where they're at least they have two or more providers where one is a non-relative community provider. People that are in extraordinary cases are recipients with a severe disability where they may even have a relative provider or a live-in provider, but because of their disability, it's so extremely difficult to find anybody to work. They need to have differential pay. This includes quadriplegics, functional quadriplegics, and persons with complex chronic conditions. But that differential pay for somebody with a complex condition, when they're over 18, they have a right to live independently in the community if that's what they want.
Connie, I wanted to make sure you were seeing the appreciation and love for you in the chat for really bravely sharing your story and your lived experience. And it's an incredible value to all of us as we continue to shape this project and work. So I just want to make sure you see all
Oh,
of
thank you, thank you.
the good vibes being sent your way.
Thank you so much. I just want to ask a question, okay?
Okay.
Is the administration planning to carve in IHSS under managed care and the medical models? Or is it planning to address HCBS wage gaps? And is it planning to address the problems with the recipient being deemed the employer and delegated to that role where we don't set the terms of employment and we can't find anybody to work? I know that's a mouthful. I apologize.
No, that's okay. I do not know if we have the right folks on the line to answer that question specifically. Joseph, I don't know if you know about, that being carved in or out, but so I don't want to put you on the spot if you don't.
Just speaking at a high level, and you've asked some high level questions there, Connie, and really appreciate all your input and experience. But I can say that it is not a goal of this gap analysis to look at a carve-in of IHSS into the managed care delivery system. So that is not something that we're specifically looking at. We are looking at the IHSS population as part of this gap analysis, but we're not specifically looking towards a goal of working to carve IHSS into our managed care delivery system. I can clearly state that.
That's why it's going to be very critical to do this differential pay. It's absolutely critical because I know where I'm going once I don't have any family members to help me. It doesn't matter how accessible my house is, I'm going to a nursing home. Because that's how you're leaving it. We're the 28 percenters. IHSS is 72% approximately of family member providers. And that's not okay. That's not Olmsted. That's not what it envisions. So I really do want you to address these critical issues. And believe me, right now, I think it's important with the state budget crisis that that now some of the social workers are starting in reassessments to ask inappropriate questions and make determinations to lower people's hours. And additionally, I don't know why all of a sudden the waiver agency, and maybe Mr. Billingsley can call me, but they're telling me there's another new formula that they've created for IHSS services that when there's a change, depending on what services you're authorized, and it hasn't changed for 2 years, that they'd have to do a calculation and they want to drop my waiver hours. And it's been hard because I lost my father in September. It's been much harder.
Connie,
I appreciate your time. Thank you.
Thanks, Connie. We appreciate it. Yes, important perspective. Thank you so much. Siri, is that your SERY? I'm sorry, I don't know how to necessarily pronounce your first name, but would love to hear from you.
Yeah, thank you so much. My name is Peter Papon. I'm the president of the ABLE Community Development Foundation based in Richmond, California. We have senior health agent, senior health and wellness, but with the word quote unquote Asia, but with the focus on the Southeast Asian. The people from Vietnam, from Laos, from Cambodia, from Thailand, and living in the East Bay, particularly in the West Contra Costa, where my program based. Right, for example, I'm a senior myself, and my wife, my mom, my sister. I have 6 immediate family. Within the 6, we have 11 senior. So one of the things that I want to share what's happening in our community is that our first generation that we came like almost 40 years ago, 30 some years ago, and we all senior now. We all senior now. Because when I first came, I was 23, my wife 21. But now I'm 67, my wife is 66 or 65. So we all faced with the issue of aging and and we have a lot of problems, a lot of problems, especially with the COVID-19, it's even more. And then I just want to share the information that when we use the term Asian, there's many different group, different nationality out there, over like 20 something country, from Southeast Asia, from South Asia, from East Asia, from many other country that locate in Asia continent, which is big, really big. I think like 2/3 of the world population are located in Asia. I happen to get the email from right here. This indicated talking about immigrant in California. It said California is home to more than 10 million immigrants. Nearly 1/4 of the nation's entire foreign-born population. The vast majority were born in Mexico, Latin America, and Asia. And 54% of California immigrants are U.S. citizens, compared to the only 31% in 1990. So and so forth is about California. Let me see here, where it's coming from. What matter? California matter. One of the major organizations that focus on the California as a whole. That I just received this email right now. So thank you so much for this opportunity. I congratulate your guy who worked so hard to try to reach out to the citizen of the California, which is big. California itself can become a mid-sized country, from like Ukraine. Ukraine is 40 million. California is also 40 million people. So it's not easy. Thank you so much.
Thank you. We appreciate your time.
Yeah.
Thank you for your comment. We are over time. So just wanted to move quickly to some next steps. I am so sorry if we didn't get to your comment or question. Please know that we are happy for you to reach out to any of us with your comments. Anything that was in the chat is on record. We will be looking at all of that in the transcript and following up with anybody who had some questions that we can still answer. We'll get back to you. No problem on that at all. Some next steps, we'll have another meeting just like this in July. We do not have a date yet, but we will have one soon, and we'll be sure to share that with you. We do have a couple of documents focused on frequently asked questions. There's one for the Department of Healthcare Services, and there's one for the California Department on Aging. There are links to those here on this slide. So lots of common questions we've answered, and those live on the websites. To share additional information, again, feedback, questions, please don't hesitate to feel free to email there. And of course, disability access is a priority. Please let us know if there were any issues or any accessibility barriers. And really appreciate you all being here. We hope you'll join us again in July. And thank you for spending so much of your day with us. We appreciate it very much. Until next time.
Thank you.